This is Jan Skowronski. Welcome to my home in Birmingham, Alabama, the land of difficult history, but also beautiful, beautiful landscape, architecture, and land of wonderful Southern hospitality. I'm going to show you a presentation now about the single most common problem or challenge that you face in endovascular procedures. The single most common case type I do is an SFA CTO. And if you would stand with me for 8 minutes on this presentation, I will teach you how to achieve more than 97% success rate on successfully treating long SFA and popliteal occlusions. And we will finish the presentation with an old 19th century proverb, which may be slightly inappropriate, that British mothers gave their daughters when they were getting married. Thank you. Let's move to the presentation. The first step I do in treating these cases, I go antegrade and intraluminal. But I have my own technique that has been adopted by many other operators, and I've been very, very successful with it. So what I do, I take glide wire advantage from Terumo 035, but I loop it at the beginning of the case. And I use a support catheter, and I typically would use angled trailblazer from Medtronic. And I never use straight wire on those cases. So this is just a typical angiogram of SFA occlusion. This is something that we all see every single day in our cath lab. So this is what I do. I advance glide wire through angle trailblazer catheter, but remember that the catheter should be angled, and the wire also is angled. And then I get a torquer at the other end, and I close the torquer, and I essentially treat it as one unit. So wire doesn't move in relationship to the catheter. Then we advance it into the 6 French sheet, and look at how I go about it. I make a loop at the entry into the sheet, and then I push it. Then when we get into the lesion, I basically forward the flipped angled wire through the occlusion, and in about 75% of cases, it goes easily, and you stay intraluminal for those cases. As you can see, we are past the occlusion, and of course the rest is simple. This is just deployment of Eluvia stent from Boston Scientific. We use actually a lot of Eluvias over the last 2 years. I think the data on Eluvia is actually real, and the rate of restenosis is really extremely low. I find it less than 10% over 2 years from what I have seen. So this is just the final result of the treatment. Well, but you have about 1 in 4 chance of getting subintimal in those cases. So then you go to step 2, and the step 2 will bring you also about 75% success rate. So you will be at combined of about 94% success rate if you master this technique. And the technique is a reentry device. As you can see on this angiogram, we crossed chronic total occlusion, but if you look carefully at the wire, it's actually extraluminal. It's in subintimal space. So what do? You use Outback. This is a reentry catheter from old Cordis, now Cardinal, and I think they're getting sold to another investment company right now. So you can see the Outback essentially next to the true lumen, distal to chronic total occlusion. And then you have a needle, and you push the wire through. And if you do that, of course, you're intraluminal above, intraluminal below. So the rest is actually simple. You can treat it with angioplasty, stents, atherectomy. Essentially, it's your choice. But what if, in some cases, the reentry doesn't really work? And this is a case that we crossed long chronic total occlusion. We are in the popliteal artery subintimally, not the great spot for a reentry. Well, then you go to the next step, step 3, that I would say it's about 70-75% success rate, and that brings you to 98% combined success rate. You do something called cart technique with dual access from the femoral artery and from pedal access. And the catheter from the femoral access, you already know that is subintimal, and the reentry doesn't really work in this case. So these are the steps. You get access into the pedal artery, and it could be AT or it could be PT or it could be even peroneal, and you push the wire in a retrograde fashion, and you dissect retrograde into the SFA level. And then you inflate a balloon from pedal access into the subintimal space in the SFA, and then you use reentry again. You essentially puncture the reentry needle into the balloon, and once you see that the balloon is being deflated, then you put the wire inside the deflated balloon, and you push the wire slowly, and you also retract the balloon down until below the knee you're intraluminal. And of course, the rest is simple. So this is just a case. You can see there is a wire in a wrong spot from above. There is a wire from below. And then we advance the balloon from the pedal access, and we have a re-entry device in subintimal space from the femoral access. And what you do, you essentially advance the needle into the balloon. You can see, poof, the balloon is getting deflated, and you push the wire into the balloon, and you slowly advance the wire and pull the balloon. And of course, the rest is simple. This is stented SFA, drug-coated balloon in the popliteal artery, and 2 vessel runoff to the right foot. What if you have a lot of calcium and your wire and catheter simply doesn't cross chronic total occlusion? Well, then you go to step 4. So this is a case, as you can see, I'm really struggling here with my own technique with the looped wire and a catheter, and it doesn't cross because of high amount of calcium. Well, then you should master at least 1 or 2 chronic total occlusion devices. And there are several. There is Wildcat from Avenger, Frontrunner, Crosser, TruePath, and Viance and Antier from Medtronic. My favorite device is actually Wildcat from Avenger. It's very powerful, but it's so powerful that it would burn through your skull if you get it in your head. And in fact, you can push through anything, and probably you will stay intraluminal in about 70% of cases, at subintimal 30% of cases. Well, if you're subintimal, then you go back to the reentry device. This is just an example of 035 glide wire and the CTO Wildcat catheter going through calcified chronic occlusion. So in summary, if you master these 4 techniques, you will really achieve over 97% success rate on long CTOs in femoral popliteal arteries. Number 1, learn the loop wire and strong catheter support technique. Learn reentry. Master cart and reverse cart with the puncture into the balloon, and get familiar with 1 or preferably 2 CTO devices. And the rest, you will see that you have a lot of success on those cases. And remember, don't be afraid to push through popliteal CTOs. We used to send these patients to surgery. Right now, it's routine to treat CTOs of popliteal arteries. So leg arteries are very permissive. So I will conclude with old 19th century British proverb that mothers gave their daughters when they were about to give birth to the baby. Just close your eyes, push, and think of England. Thank you very much from Birmingham, Alabama. I will conclude here.